I'm pleased to introduce Rhonda McNicoll-Whiteman. Rhonda is a stroke best practice clinical nurse specialist at Hamilton Health Sciences. She supports teams within Hamilton Health Sciences and the Central South Regional Stroke Network to implement best practices for stroke care across the continuum. Rhonda received her Bachelor of Science in Nursing from McMaster University in 1989 and her Master's of Nursing from the University of Toronto in 2008. She is a part-time assistant clinical professor at the School of Nursing, Faculty of Health Sciences at McMaster University. And Rhonda has presented a number of papers at regional, provincial, and national conferences over her 37-year nursing career and in neurosciences at Hamilton Health Sciences. Thanks, Rhonda, for joining us this afternoon.
Thank you so much. And thank you so much for inviting me to participate. I'm going to share my screen and I apologize. I've come down with a bit of a bug, so I apologize if I sound a bit hoarse as we're going along. Hold on. Perfect. So I have nothing to disclose for this talk. And really what I'm hoping to do is really do a bit of a basic review of anatomy, physiology, and cerebral circulation, review stroke pathophysiology, and review some clinical presentations of common ischemic syndromes. I always like to frame presentations when I talk and really look at, we know the impact of stroke can be devastating in Canada. We know stats from 2017 is there's approximately 108, just a little over 108,000 new strokes each year, which equates to someone having a stroke every 5 minutes. We also know that stroke is the leading cause of adult disability. And so as a result, all of our interventions, which I know you've talked about today, are really focusing on decreasing the disability after stroke. So decreasing, from our hyperacute, our stroke unit care, our rehabilitation and prevention. We also know stroke is the third leading cause of death. So we know that some of our patients will succumb as a result of their stroke. We also know that when someone has a stroke, the risk of having a recurrent stroke is about 26.4% at 5 years. So there's a real need for aggressive secondary stroke prevention management. We know the risk of stroke increases as doubles every decade after the age of 55. However, that does not mean that stroke is a disease of the aged. What we have seen is that the number of adults over the age of 20 that have experienced a stroke has steadily increased since 2003. We know that about 25% of all of the strokes are happening those in the young. And what do I mean by young? 20 to 54. So let's start with doing just a bit of neuroanatomy review. So if we go back to our basic neuroanatomy, we know the brain is divided into 3 main areas: the cerebrum or the cerebral cortex, the cerebellum, and the brain stem. When we look at the cerebrum, we know it has 2 hemispheres that is connected by the corpus callosum. We know that each hemisphere controls the lateral side of the body. So the right hemisphere controls the left side of the body, movement, sensation, and vision, and the left hemisphere controls the right. In addition, we know that the left hemisphere really is more of our analytical tasks, those such as science, math, numbers, and reasoning. We also know in the left hemisphere, it is also where our speech and language center is. So really understanding speech, expressing speech, reading and writing. When we look at our right hemisphere, in addition to controlling the motor sensory and vision on the right side of the body or the left side of the body, it really is more of those artistic, creative sides. It also controls in our parietal lobe our spatial orientation, and so can be quite problematic if patients have damage there, and we'll talk about that in a little bit more. We know the cerebral cortex has 4 lobes: the frontal, parietal, temporal, and occipital lobe. The frontal lobe is the largest, making up about 60% of the cerebrum. It has 3 main functional areas. First is the prefrontal area, so very much right at the front of the brain, which is really all of those higher executive functioning: concentration, abstraction, memory, judgment, insight, emotions, tact, sequencing of behaviors. Also, Broca's area for our expressive speech center is in the left hemisphere in the majority of people. So this looks at our word formation, articulation, pronunciation, voice, and speech production. Right at the back of the frontal lobe is our motor cortex, which controls voluntary motor movement on the opposite side of the body. When we look at the parietal lobe, again, this is sensory control on the opposite side of the body. It's looking at all various modalities. So point discrimination, pressure, temperature or texture, body interpretation, orientation, pain, proprioception, visual perception. Again, the sensory cortex is right behind the motor cortex. And again, that is laid out in the sensory homunculus in a topographical area, giving different parts of the body different representation. When we look at the parietal lobe or the temporal lobe, this is our primary auditory center. It receives, discriminates, and interprets sounds. It also is our Wernicke speech area, which looks at our receptive language, our comprehension. It also integrates all of our somatic, auditory, and visual stimuli, looking at our memory and our emotions. When we look at our occipital lobe, this is our primary visual receptive association areas of the brain. The occipital lobe, the visual pathways come back from the eyes, back to the visual cortex, so it looks at our different visual fields, but it is also our spatial orientation of vision, sharp borders, colors, contrast, and visual integration. Here you can see on the motor and sensory homunculus, so the motor is on the right, you can see that the homunculus starts sort of at the medial aspect, and you can see starts with sort of the leg, foot come out, and you can see different areas of the brain are controlled by the motor and sensory cortex. When we look at our diencephalon, this is really looking at the deep structures within the brain. And so looking at our thalamus, hypothalamus, and our basal ganglion. The thalamus is that relay center to other parts of the body for sensation and motor. What we then look at, all of the sensory and motor pathways have a direct connection to the thalamus. Deficits that affect the thalamus could be contralateral hemiparalegia, contralateral hemisensory deficits, and vertical and gaze preferences. We know our hypothalamus really processes all internal stimuli for the autonomic nervous system, maintaining our heart rate, heartbeat, our heart rhythm, our body temperature, our metabolism, our fluid osmolarity, our feeding responses, and our pleasure. When we look at our basal ganglion, it's where we produce dopamine and really coordination of those muscle movements and posture. When we look at patients who have deficits with the basal ganglion, they have difficulty with movement and posture. They lose postural reflexes. They may have tremors. They may have rigidity and involuntary movement. What you can see when you look at the boundaries of the diencephalon is the wall of the third ventricle, the midbrain, at the base of the hypothalamus, and you can also see the lateral border of the internal capsule. When we look at the cerebellum and the brainstem, we know the cerebellum really coordinates the fine motor movements, coordination of muscle groups, and really maintaining balance and equilibrium. I often think of patients who have difficulty in their cerebellum is if you think about some of those roadside tests, they have a broad staggering gait, they can't do a heel to toe. If you ask them to do a finger to nose, they are very jerky and they overshoot. Our brainstem is made up of the midbrain, pons, and medulla. Really is our CPU of our brain. It really controls all of our vital functionings, our heart rate, our blood diameter, blood pressure, respiratory rate, our vomiting, our coughing center. Our reticular activating system is at the level of the midbrain, and that is really looking at our level of alertness, our arousal, our level of consciousness. It also houses all of the cranial nerves. Cranial nerves 3 to 12 originate at the level of the brainstem. When we look at our cerebral circulation, the brain has a higher requirement for oxygen and glucose than any of the other organs in the body. Approximately 20% of the resting cardiac output is supplied to the brain at a rate of 80 to 1,000 mLs of cerebral blood flow per minute. The brain is deprives its arterial supply by a pair of carotid arteries that supply the anterior circulation and two vertebral arteries that provide the posterior circulation. The internal carotids and its branches supply 2/3 of the cerebral hemisphere. It originates off of the enamelate artery of the aorta. It gives rise to the tympanic and ophthalmic arteries before it enters the brain, and then branches off into the anterior cerebral artery, middle cerebral, and posterior communicating artery. The posterior circulation is made up of the vertebral artery and its branches. The vertebral and basilar arteries supply the medial, posterior medial regions of the hemispheres, the brainstem, diencephalon, cerebellum, and cerebral spinal fluid. The vertebral arteries originate off the subclavian, enter the brain through the foramen magnum, at the base of the skull, unite at the level of the pons to become the basilar, and then divide into two posterior circulation arteries. Here, when we look at anterior circulation, you can see the anterior cerebral arteries supply the anterior aspects depicted in yellow of the parietal and frontal lobes. When we look at the middle cerebral artery, depicted again in the red, it supplies 2/3 of the cerebral cortex, the deeper brain structures, the temporal lobes, and more lateral or external aspects of the brain. When we look at the posterior circulation, what you can really see is the vertebral arteries supply the cerebellum, the brainstem, and the posterior aspects of the occipital, temporal, thalamus, and midbrain. We know that the circle of Willis is a network of joining arteries that form that consistent structure to allow blood flow to compensate in the event the blood flow is blocked in one area. The anterior communicating arteries join the right and left anterior circulation anterior circulation, and the posterior communicating arteries allow for connection of the anterior and posterior circulation. These communicating arteries are in a low flow state, but will activate to flow or shunt blood throughout the brain as necessary. How good the collateral circulation is dependent on that patency of the circle of Willis vessels. Not all patients have as patent or intact circle of Willis, and so as depicted here, and if it is not, that can be challenging. How effective the vessels are to provide collateral circulation really depends on the vessel size, if they have stenosis, the presence of atherosclerosis, if the circle of Willis is intact, and how sudden the blockage is. We do use, for those at the hyperacute sites, our sort of multi-phase CT angiogram to really assess some of that collateral circulation. Sue, do you want to bring up the polls? So we'll start with the first is, what is the key impairment of patients with right parietal hemispheric damage? Is it speech and language deficits, neglect, right-sided motor weakness, or a left gaze preference? The second question is, what is the purpose of the circle of Willis? Does it connect the right and left cerebral circulation? Create a connection so blood flow can be shunted to compensate for an artery that is blocked or damaged, connect the anterior and posterior cerebral circulation, or all of the above? I'll give just a couple minutes, and so you can let me know how people are responding.
Yeah, they're just starting to answer now. Just give them a few seconds. Do both questions, please. I put them together, so. Okay.
Perfect. So yes, the right parietal hemisphere in patients, because of that spatial integration, patients can present with neglect. And again, the circle of Willis, correct, is all of the above. So great. So let's now move on to stroke pathophysiology, and we'll start with the modifiable risk factors. I'll pull them all up so they don't come. So we know age is a significant risk factor for stroke, with about 75% of strokes occurring in individuals greater than or equal to 65. As I said earlier, the risk of stroke rises rapidly for individuals after the age of 55. We also know prior stroke or TIA or heart disease are significant risk factors for stroke. Family history, patients who have a large stroke are 3 times more likely to have a first-degree relative who suffered an early stroke or heart attack. This risk is greater if the parent, grandparent, brother, or sister had a stroke or heart attack early. If it's on the parent, the father's side, that risk is increased 2.5. And the maternal, if it's on the mother's side, that risk is increased 1.5 or 1.4 times. When we look at socioeconomic status, we know that almost half of our stroke-related deaths are attributed to poor management of modifiable risk factors, thus are potentially preventable. Despite improvements in general health knowledge, access to healthcare, and preventative strategies, socioeconomic status is still strongly associated with modifiable risk factors and stroke burden. So screening patients from low socioeconomic status at higher risk is crucial. When we look at genetics, women at a younger age have a higher risk of stroke than men due to pregnancy, postpartum state, hormonal states such as hormone contraceptions, and also postmenopause. We also know women have a longer life expectancy than men, so have more strokes. When we look at ethnicity, we know our Indigenous heritage, Six Nations, Métis and Inuit, our African and South Asians have a higher risk of stroke than the general population, likely due to higher rates of hypertension and diabetes earlier, at an earlier age. When we look at our modifiable risk factors, hypertension is the #1 risk factor for primary and recurrent strokes and is an important modifiable risk factor for ischemic and hemorrhagic stroke. It accounts for about 54% of the risk of cerebral vascular disease. There also is a strong link between higher the blood pressure, the higher the risk of stroke. Diabetes is a major risk factor for stroke, accounting for a 2-fold risk of stroke. It is a very potent risk factor in younger people, increasing the risk of stroke 1.5 to 3 times. It doubles the rate of stroke recurrence and has an impact on outcomes, accounting for 20% of the stroke death in diabetes. Patients who are pre-diabetic are also at risk of stroke. Atrial fibrillation and atrial cardiopathy, a long recognized major risk factor for stroke, accounting for about 20% of all strokes. We know that the risk of atrial fibrillation increases with age and has tripled over the last 30 years. Atrial fibrillation causes a stasis of blood in the left atrium, which causes thrombus formation and embolism to the brain. We know high cholesterol is complex with an associated increased risk of stroke in increased total cholesterol. Inactivity is associated with many poor outcomes, including stroke, and have a higher risk of stroke. People who are inactive have higher rates of hypertension, diabetes, and increased risk of excessive body weight. There is evidence of the benefit of exercise in reducing the risk of stroke. Body weight and obesity are risk factors for stroke, causing hypertension and diabetes. There's a growing concern for obesity in the Canadian population, especially in younger adults. 28.4% of stroke burden is attributed to a high BMI. We know metabolic syndromes incorporates obesity, dyslipidemia, prehypertension, and diabetes. We know a healthy lifestyle reduces the risk of stroke and the risk of subsequent stroke for persons with a prior stroke. Current research reports estimate that reducing sodium in food would abolish high blood pressure in almost 1 in 3 Canadians. About 77% of the sodium we consume comes from processed foods sold in grocery stores and food outlets. Only 11% is added in preparation or at the table. Available evidence suggests lowering stroke consumption to adequate intake levels could reduce the incidence of stroke and heart disease by as much as 30% and have a significant impact on lowering blood pressure. Smoking is also a major risk factor for stroke. The Quality of Care study found that all Canadians, about 41% were current smokers, more prominent in younger adults, less than the age of 49, and current smokers have an increased risk of stroke with a greater impact, with an impact greater on ischemic stroke than hemorrhagic. We know that excessive alcohol use is an increased risk of ischemic and hemorrhagic stroke. We also know the abuse of illicit substances is associated with an increased risk of ischemic and hemorrhagic stroke. We also know inflammation and infection, levels of inflammatory biomarkers are associated with an increased risk of stroke, but those reasons are unknown. So when we look at TIA, this is a temporary blockage of blood flow caused by a clot. The symptoms usually resolve within minutes and almost all within an hour. We do know patients who have fluctuating symptoms or recurrent symptoms within 24 to 48 hours are at very high risk for developing a stroke. If your patient has persistent stroke symptoms, it is not a TIA, but maybe a stroke. A TIA is a major warning sign that a stroke may occur. We know that about 10 to 20% of TIA patients will develop a stroke in 90 days without implementation of appropriate secondary stroke prevention. TIA patients who are discharged from the emergency department should have a referral to the secondary stroke prevention clinic. When we look at the stroke, it's an interruption of the blood flow to the brain. When that blood flow is interrupted, the brain becomes damaged or dies. In stroke, it can either be caused by a blockage, an ischemic stroke, or a bleed, a hemorrhagic stroke. We know that ischemic strokes account for about 87% of the strokes we see, and hemorrhagic about 13%. So now let's go on to ischemic stroke. In ischemic stroke, the blood vessels supplying the brain becomes blocked. This results in decreased blood flow. There are four main types of ischemic stroke that we'll go through. When we look at a large vessel thrombotic or atherosclerosis, this is where the artery narrows with plaque and atherosclerosis over time until it becomes completely occluded. We know it's the most common. Intracranial atherosclerosis is the leading cause of ischemic stroke worldwide, with the risk factors being increased age, Asian and Black race, hypertension, diabetes, hyperlipidemia, metabolic syndrome, sedentary lifestyle, and smoking. When we look at our small vessel thrombotic strokes, or also called a lacunar strokes, this is a marker of cerebral small vessel disease and accounts for about 25% of all ischemic strokes. Small vessel lacunar strokes can affect either the anterior or posterior cerebral arteries. It's caused by small microplaque and thrombosis of the small penetrating or perforating arteries of the vessels. Predominantly affects the basal ganglion, the putnam, and the thalamus. Lacoon comes from the Latin word meaning lake, which is used to describe the post-healing processes or the small cavities that occur in the brain. When we look at the risk factors for small vessel strokes, often is uncontrolled hypertension, diabetes, advanced age, smoking, and hyperlipidemia. When we look at an embolic stroke, sorry, I'm spinning. Oh, nope. I'm going to stop sharing and I'll re-share again.
Okay.
When we look at embolic stroke, this is where a blood clot travels from outside of the brain. The clot travels from its origin through the carotid arteries to a vessel in the brain where narrowing occurs. It often is the middle cerebral artery, which is really purely because the middle cerebral artery is right off of the internal carotid and is one of the larger arteries. Often we see this as cardiac related, either due to infective endocarditis, valve disease, atrial fibrillation, ventricular thrombus, atherosclerosis of the proximal aorta. Typically, this affects younger people and occurs when they are awake or active. We know that there are less common types of strokes that we see. I often describe strokes as ischemic strokes as a plumbing problem, either a problem of the pipe, the pumps, or the fluid. And so in this case, when we look at coagulopathies, hypercoagulability or thrombocytopenia is a group of hereditary or acquired conditions that result in the propensity to develop thrombi or clots in the veins, arteries, or both. Most common hypercoagulable states are genetic states that affect the clotting factors or disorders affecting the clotting proteins. However, acquired risk factors may be major surgery, malignancies, immobility, oral contraceptives, estrogen replacement therapy, antiphospholipid antibody syndrome, heparin-induced thrombocytopenia, smoking, obesity, and nephrotic syndromes. We also know that there are less common causes that may affect the arteries. So when we look, and these are kind of grouped together that cause a bit of an inflammation. So we sometimes will see giant cell arteritis, whereas an inflammation or irritation of the lining of the arteries that causes an inflammatory response. We also know that cocaine can cause spasming of the artery. We also know that the vessels may become dissected and a clot forms. When we look at cryptogenic strokes, also called embolic strokes of unknown source, this is really challenging in an area of significant research focus. It remains a diagnostic and management challenge. Anywhere between 50 to 40% of all strokes, or approximately 25% of all strokes on average. The diagnosis is made on the exclusion of other causes. The etiology is thought to be likely an embolic source related to either undiagnosed paroxysmal atrial fib or an embolus from a patent form in ovale or a thrombotic state from an unknown malignancy. The challenge in cryptogenic strokes is, we know with embolic strokes, we really want to get patients on anticoagulant, and it's very challenging because we don't know the appropriate secondary prevention. This slide just really summarizes, again, which I've talked about, sort of what is that breakdown, and again, looks a bit at that sort of pump fight fluids when we look at stroke. Moving on to hemorrhagic stroke, this is a result of a burst blood vessel, most often occurring to the arteries deep within the brain. The symptoms of hemorrhagic stroke can closely mirror those of ischemic stroke, but have some very distinct differences. May result from a decreased level of consciousness, sudden severe headache, uncontrolled hypertension, vomiting, focal neurological deficits. We also know that patients may deteriorate. About 50% can progress quite quickly, with 50% deteriorating within the first 48 hours due to increased intracranial pressure. When we look at increased intracranial pressure, we know in adults, the skull is rigid, non-expandable, and non-compressible. The volume within the skull is made up of 10% blood, 10% CSF, and 80% brain tissue. We know that any alteration of one of these components without a response to the other can lead to changes in increased intracranial pressure. And so if we have a sudden increase in blood pressure, you're going to see right-left shifting. You may then see pressure down on the brain stem, and that's where you see that sudden deterioration. So when we look at the types of hemorrhagic stroke, there are two main, intracerebral hemorrhage and subarachnoid. Intracerebral hemorrhage is when an artery ruptures within the brain. The collection of blood leads to compression of brain tissue. As I said earlier, often occurs in the arteries deep within the brain. Hypertension is the leading cause of stroke, as the increased pressure of the wall shears until it weakens to the point of breaking. Other common causes are cerebral amyloid angiopathies, so the conchophilic material deposits in the small to median vessels of the artery, which weaken it and cause it to rupture. We can also see vascular malformations, which are congenital malformations of the artery and venous system, which cause weakening in the arteries that can rupture. We also know anticoagulation therapy is also a cause. Approximately 35% of the intracerebral hemorrhages occur in the lobes of the brain, 50% deep within the brain, the midbrain or brainstem, and 10% within the cerebellum. Intracerebral hemorrhage caused by hypertension have a 30-day mortality of 10 to 50%, depending on the location and size. Patients who have interventricular hemorrhage or hydrocephalus is an independent of 30-day death. If the hematoma is continuing to expand, it results in a 5-fold increase in death and outcomes. And ICH related to oral anticoagulants have a high mortality. The strongest predictor of death in 30 days is the volume of blood and that initial presentation. When we look at a subarachnoid hemorrhage, it's defined as blood between the arachnoid membrane and the pia and both layers of the dura mater. The majority of time, it's from a congenital-derived arterial outpouching of Barry aneurysms that lie at the bifurcation of the main components of the circle of Willis. We know that the signs and symptoms of subarachnoid hemorrhage can look a bit different. They may be younger. They may have a loss of consciousness. They may have double vision or light sensitivity. They may have neck rigidity. They may have nausea and vomiting. They often describe this severe thunderclap headache as the worst headache of their life. Patients presenting with a intracerebral hemorrhage or subarachnoid require evaluation by neurosurgery and may require transfer out to a neurosurgical center. I'll have Susan pull up the polls. So here we'll look at hypertension is the #1 modifiable risk factor for ischemic and hemorrhagic stroke. True or false? True or false, the etiology of cryptogenic stroke is likely an embolic stroke. And finally, true or false, it's important to monitor your intracerebral hemorrhage patient for signs and symptoms of increased intracranial pressure for the first 48 to 72 hours.
Okay, we'll just give them a few seconds to respond to all 3 questions, please. Okay.
So yeah, perfect. True, hypertension is the #1 modifiable risk factor for both ischemic and hemorrhagic stroke. True, embolic stroke is thought to be the etiology of cryptogenic stroke. And absolutely, our intracerebral hemorrhage patients are at risk for that signs and symptoms of intracranial hemorrhage or intracranial pressure, and really important to watch them very closely. So let's move on and we'll wrap up looking at sort of the stroke syndromes. So when we look at anterior stroke syndromes, these symptoms, so this is, as we said, really looking at our anterior cerebral artery and our middle cerebral artery. Typically, these patients have contralateral weakness of the and sensory loss to their face, arm, and leg, difficulty speaking and understanding language if it's on the left. They'll have a homonymous hemianopsia, incontinence, difficulty planning, organizing and change in behavior. So if we look at our middle cerebral artery, this is the most common type of stroke that we see. We know that the middle cerebral artery supplies blood to the lateral aspects of the frontal, parietal, and temporal lobe. Patients will present with hemiplegia of the face, arm, and leg, sensory deficits of the face, arm, and leg, homonymous hemianopsia, aphasia if it's on the left, confusion, neglect if it's on the right, and headache. When we look at our anterior cerebral artery, these are not as common. These are looking at about 1 to 4% of the strokes we see. The anterior cerebral artery supplies the superior medial aspects of the parietal lobe and the midline of the frontal lobe. So we will see sort of that motor and sensory of sort of that of the motor and sensory strip. The patient's going to have paralysis of the lower leg, sensory loss to the toes, foot, and leg, impaired gait. They'll also have incontinence because of the innervation of the bowel and the bladder. And really what becomes is also that prefrontal cortex. So the patient may have a very flat affect, even though they may not have significant deficits and can maybe complete ADLs or eat. They really have difficulty initiating. They're very apathetic. They'll also present with executive dysfunction. So they may have difficulty sequencing. They may have inappropriate emotional liability, lack of impulse control. They may be sexually inappropriate or verbally inappropriate in their speech, which can be very challenging. So sorry, I don't know why. I must have clicked the link. I'll stop sharing it again. I'm not quite sure why that comes. When we look at our lacunar stroke syndromes, as I said, this is about 25% of the stroke we see. Results of occlusion of the perforating arteries of the anterior and posterior intercerebral arteries. These patients may present with worsening symptoms over a few days. So they may present a couple days after, and there are 5 main types that we see. We know that patients may present with either pure motor stroke symptoms, pure sensory symptoms, sensory motor stroke, ataxic hemiparesis, dysarthria, and clumsy hand syndrome. When we look at, sorry, I don't know why, I think I may, there we go. When we look at our posterior stroke syndromes, they're posterior circulation syndromes. These account for about 20 to 25% of all the ischemic strokes. These may be missed in the emergency department. I often describe posterior circulation strokes as a range. They either come in with the ambulance, the paramedic crew, intubated, ventilated, perhaps with a Glasgow Coma scale of 3, so they're very sick, or they can come in with more vague symptoms, dizziness, a vertigo, imbalance. We know that about 25% of posterior circulation strokes will have a TIA prior to their stroke. It can be double vision, monocular blindness, vertigo, impaired sensation, one-sided cranial nerve deficits, and contralateral motor and sensory symptoms. Fleeting or stuttering symptoms are concerning and should prompt evaluation for basilar artery occlusions. We know that posterior circulation strokes have a higher disability, risk of disability versus anterior circulation strokes at 3 months. When we look at our sort of posterior circulation strokes, if we look at the upper vertebral system, those are posterior cerebral artery strokes, middle are the basilar, and then lower are the vertebral artery and the cerebellum. When we look at our posterior cerebral artery strokes, it accounts for about 5 to 10% of the strokes we see. They can be quite variable and challenging to diagnose because they may have variability in symptoms, which may be inconsistent. Because the posterior cerebral artery supplies multiple areas, the occipital lobe, the temporal lobe, the thalamus, and the midbrain, patients may have different deficits. So they may have visual field deficits, homonymous hemianopsia. They may have visual agnosia, so they may not be able to recognize objects. They have cortical blindness, inability to recognize familiar faces, difficulty reasoning, visual hallucinations because they're not able to interpret the stimulation, the visual stimulation, loss of color differentiation. If we're looking at our medial temporal lobe, they're going to have transcortical aphasia. So they have poor auditory comprehension, but with intact repetition, they can repeat what they hear. They may have memory impairment, behavior alterations. They may be agitated or paranoid. If we look at the thalamus, that they can have contralateral sensory loss, confusion, dysarthria, decreased level of consciousness, and memory impairment. When we look at some of our brain stem strokes, if we look at our midbrain and our pons, you can see there are a bit of similar symptoms. If we're looking at our midbrain, because what we typically see is a third nerve palsy, particularly down and out in the eye. it's because there's complete involvement of the levator pabili saprea. So they have complete ptosis, they have paralysis of their extraocular eye movement, and complete pupillary mydrosis. When we look at our pontine strokes, these patients may have ipsilateral signs. They may sometimes described as having mixed motor and sensory signs. So they have ipsilateral signs. So they have a Horner's syndrome, where they have a constricted pupil and a droopy eyelid. They have double vision because of the eye movements are not coordinated. And they may have seventh nurse palsy with the whole face being weak. So the forehead, the cheek, and the jaw. Versus what we see with cortical strokes typically are the cheek and lower portion. They may also have contralateral signs. So they may have weakness of the arm and leg and sensory loss of the arm and leg because the cortical motor and sensory fibers have already crossed at the level of the midbrain. They may also have nystagmus, so that rotary or lateral or vertical eye movements. And they may also have nausea. When we look at top of the basilar, these patients can come in either with, as I was talking about, with that unresponsiveness. They may come in with hallucinations, behavior change, disorientation. They may have altering level of consciousness, visual deficits, nystagmus, ocular motor blindness, and cortical blindness. When we look at locked-in syndrome, this is a very unfortunate, debilitating type of stroke that we see in the lower pons caused by occlusion of the mid-basilar artery. The patient has complete paralysis of the arms and legs. They have a horizontal gaze preference. They have bifacial paralysis, tongue, mandibular weakness, no inability to speak, no facial movement, dysphagia, and unresponsiveness to painful stimuli. They're able to hear, see, but may only be able to communicate with their eye movement. They're almost like a quadriplegic with also not being able to communicate, speak. They may have a PEG, they may have a trach. Incredibly disabling strokes. When we look at our lateral medullary syndrome or our Wallenberg syndrome, these are infarcts that are affecting the lateral medulla of the brainstem as a result of the occlusion of the superior cerebellar artery. These patients, because they may not have much motor deficits, may actually not look as impaired, but are at significant risk. They'll have vocal hoarseness, they'll have a poor tone, they'll have nystagmus, diplopia, vertigo, nausea. They'll also have that Horner's syndrome. They'll have reduced pain and temperature sensation. They are significant dysphagia. They have no gag. They may have difficulty tolerating their secretions. They have an impaired cough, wet voice quality. They may be unable to initiate a swallow, and so are at increased risk for pneumonia, may require mechanical ventilation and a trach. They may also have ipsilateral gait, ataxia, and difficulty in maintaining a sitting position. When we look at our cerebellar strokes, these account for about 1 to 4% of the posterior circulation strokes that we see. This stroke involves the posterior fossa and the cerebellum. It's caused by occlusion of the superior anterior and posterior inferior cerebellar artery. It really is important. Their symptoms may be ataxia, vertigo, nausea, vomiting, dysarthria, and nystagmus. It's really important to watch these patients closely because they may have rapid deterioration in that level of consciousness if they have edema. And so if you think about that increased intracranial pressure, the only opening is at the base of the skull of the foramen magnum. And being in the posterior fossa, there's very limited ability if it's cerebral edema to then have compression on the brainstem, which can cause herniation. Surgical decompression may often be necessary if they have deterioration in their level of consciousness and may require neurosurgery. I'll turn it now over to Sue and we'll go through a couple of cases. And as we wrap up. So
I
in our
have the
first
questions,
case,
if you want to show the case and then they could answer the first question and then I
okay,
can
perfect.
show it if you'd like the answers.
Okay, perfect. So great. Thanks, Sue. So the first case is a 56-year-old female who presented to the emergency department by ambulance after her husband observed her to collapse. When he went over to assist her, she couldn't speak. She had right-sided facial droop and couldn't move her right arm or leg. So what type of stroke do we think she has?
Give them a few seconds. Don't be shy. I'll just end it and then I can relaunch it for the next one. So here's the first one.
Yeah, so perfect. Most of you got it. It is the left middle cerebral artery stroke. She has it's in the left hemisphere because she has the aphasia and the right-sided facial droop and not being able to move her eyes or her arm or leg. So let's go to the second case. Oh. We have a 34-year-old female who developed the worst headache of her life this morning. It was accompanied by neck rigidity, light sensitivity, nausea and vomiting, and mild weakness on the right side and drowsiness. So what type of stroke do we think it is? A middle cerebral artery stroke, a cerebellar stroke, an intracerebral hemorrhage, or a subarachnoid hemorrhage?
You're answering question number 2. Lots of different ideas this time. Give a few more seconds. Okay.
And so in this case, really what we see here is that worst headache of her life, that thunderclap headache, the neck rigidity because of the irritation of the lining of the meninges with the blood, the light sensitivity, it's a subarachnoid hemorrhage.
Subarachnoid.
All right, so let's move on to case study 3. So we have a 73-year-old female presenting to the emergency department with a 2-day history of right leg weakness and slurred speech. She didn't want to bother anyone, but when her right hand and arm became weak, she called 911. She has a history of hypertension. She's a non-insulin diabetic. Her CT shows small infarcts and previous small infarcts in the same area. So what type of stroke do you see? And so this is case study 3. Is it a lacunar stroke, an anterior cerebral artery stroke, a left middle cerebral artery stroke, or a right middle cerebral artery stroke?
Seconds. Okay.
So yeah, most have gotten it. It is the lacunar stroke. It is that sort of fleeting symptoms. Again, sometimes with those patients who have a small infarct, often will then show that they've had recurrent infarcts that are covert in that they're not hitting an area that may cause symptoms. So 2 more, and then I'll get you out on a Friday afternoon. So case study 4, an 80-year-old man who complained of severe headache and nausea vomiting to his wife. She observed him collapse at home with decreased level of consciousness and right-sided weakness. She immediately called 911. He was brought to the closest hospital. In the emergency department, his blood pressure was 230 on 120. He had significant decreased level of consciousness, requiring intubation and a severe right-sided weakness. So what type of stroke do we think this is? Is it an anterior circulation ischemic stroke, posterior circulation ischemic stroke, intracerebral hemorrhage, or subarachnoid hemorrhage?
Okay, study 4. Okay.
Great, absolutely. Intracerebral hemorrhage, perfect. All right, so now we'll go to the last case. So a 73-year-old female who woke up this morning with no symptoms. She spoke to her husband and walked to the bathroom. Her son found her 50 minutes later, collapsed on the floor with decreased level of consciousness and left-sided weakness. In the emergency department, she was drowsy but rousable, was having difficulty protecting her airway. She has bilateral itosis, partial gaze preference, left-sided facial weakness, left-sided arm and leg hemiparesis. Where do we think the stroke is? Do we think it's a lacunar, a middle cerebral artery, a cerebellar, or a basilar artery stroke?
Another second. People are thinking about this one. Okay.
So yeah, so again, it is sort of that basilar artery stroke where you're seeing that ptosis, the involvement of the cranial nerves, the decreased level of consciousness. Really, that's what we're looking at. Great job, everybody. I know it's late in the afternoon. In conclusion, it's really important to understand neuroanatomy and physiology so you can recognize those signs and symptoms of the various stroke syndromes in your patients so you can anticipate the deficits your patient may have and plan your care accordingly.
This was a good refresher review of anatomy, physiology, and pathophysiology of stroke. Some of the words you say, Rhonda, I don't even know what they are. Just say it. And you just say them with such confidence. So you have lots of knowledge and lots of background.